Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to Dr Becks Fisher, who's a GP and the Director of Policy and Research at the health think tank, the Nuffield Trust. Becks has long been an advocate for overhauling GP funding so it better reflects deprivation. And in this conversation, she explains why this is so important and how the government could go about doing this. She also outlines her views on the government's plans to move care from hospitals to the community, create a neighbourhood NHS and incentivise continuity of care, and discusses what the Nuffield Trust wants to see in the 10-year plan, as well as offering advice to other GPs who might be interested in a career in policy work. I'm delighted to be joined on the podcast now by Dr Becks Fisher, who's a GP and the Director of Research and Policy at the health think tank, the Nuffield Trust, a role she took on in July of this year. Before that, she was a Senior Policy Fellow at the Health Foundation, where she led on its primary care portfolio. Thank you so much for coming on the podcast, Becks.
Thanks so much for having me, Emma.
You combine being a GP with policy work now as the Director of Research and Policy at the Nuffield Trust. How did you get into policy work in the first place?
Partly it was really wanting it to happen and then being lucky enough to be able to make it happen. So I think I'd probably describe myself as a political animal. I have been ever since I remember. I think I'm someone who, I guess, feels a very strong sense of injustice about lots of things and roots that really as a commitment to social justice. And for me, from when I was a medical student, or probably even thinking about why I wanted to be a med student in the first place, health and healthcare has been a route into that. I've always worked as a GP in socioeconomically deprived areas, and like so many GPs listening to this, for a long time understood that so much of what makes our patients sick or well lies really outside our consulting room or our direct remit as GPs to be able to fix. And I think in many ways, I've always wanted to change that too a bit, to be a GP and to do the best I can for the patient in front of me, but also in some way to be able to contribute, I hope positively, to making the wider world a more equitable place and that works better for more people and for my patients. And I think for me, that's where research and policy comes in. So I did academic clinical training. I was really fortunate to spend 4 years in an academic research department, learning research skills. I'm really motivated by taking rigorous evidence, by applying it to policy and political cycles, and fundamentally then to try and get better evidence-led policy. And my personal path to that led through academic training to then becoming a National Medical Director's Clinical Fellow. So Bruce Keogh was National Medical Director at the time. I learned a huge amount from that fellowship, and then was really fortunate to be able to stay on at the Health Foundation, which is an amazing organisation, amazing place for me to learn and develop, and also then to develop and lead its portfolio of work on primary care. I spent a bit of time in America as a Harkness Fellow, and now here I am at Nuffield as Director of Research and Policy. And honestly, every morning I wake up, whether I'm in general practice or here at Nuffield, just feeling like I'm incredibly lucky to have these jobs and to get to be this interested and motivated in what I do.
And what does your role at the Nuffield Trust involve now? What is it you actually do there?
So I'm Director of Research and Policy. The Nuffield Trust is a health think tank. We produce lots of research and analysis aiming to inform better public policy to improve health and healthcare in the UK. And my job really is to lead our amazing team of researchers and analysts. So there's an incredibly broad portfolio of work at Nuffield, from NHS finances to workforce, primary care, social care, end-of-life care, maternity care. We do major service evaluations. Part of my job is about research, so doing it myself, but a lot of my role now is helping other people with their research, setting our strategic direction as an organisation in terms of our research and policy portfolio. And a big part of it actually is about communication of Nuffield's work. We're not doing research to send it out into a vacuum. We want our work to inform government health policy, to inform the service people working in the NHS, to shape NHS and social care to make it better. So communicating our work is really important.
You mentioned that you've worked in socioeconomically deprived areas, and I know that one of your areas of interest is around health inequalities and GP funding. You've been calling for an overhaul of GP funding for a number of years now because you believe that the current way general practice is funding really exacerbate health inequalities. Why is that?
I guess let's just take a quick step back here and say that I want to separate out two things here. One is the overall slice of the pie that general practice gets, which of course I think should be bigger. But I also think that we need to then divide that pie better between practices. And I think that's at the root of your question. So to me, the funding of general practice is completely perverse. So we know that there's significantly greater health need in poorer areas. That translates, of course, into greater demand for general practice. So, for example, consultation rates, the number of consultations each person has per year, is higher in poorer areas. In 2020, people in the most affluent affluent areas had about 4 consultations per year with the GP, but it was 5 per year in the poorest areas. Despite that increased need in poorer areas, general practice in those areas is underfunded. So practices in the poorest areas of the country receive on average 9.6% less funding once you adjust for need than practices in most affluent areas. So in poorer areas, you have more health need, but less funding for practices, which to me has always seemed completely perverse. And unsurprisingly, since practice income in part determines the mix of staff you can employ, how much you can pay them, how competitive an employer you can be in a context where we have undersupply of GPs, practices in the most deprived areas also have fewer GPs. If we're serious about tackling health inequalities, we need provision of healthcare to line up with need in the population, i.e. we need the greatest provision of general practice in the areas where we have most population need. At the moment, we have the opposite of that. And actually, we've had this situation in general practice in England for a long time now. The formula that really lies at the root of this problem was introduced in 2004. But very worryingly to me, in recent years, we're starting to see that we're probably suffering ill effect as a result of it. So we all know that consultation rates in general practice are going up and up, demand is rising. But actually the data shows that increases in consultations are greatest in the most affluent areas since the pandemic. Now, if we just think about that for a moment, we know intuitively that doesn't make sense, does it? We know that demand will be rising faster in the poorest areas, but consultation rates are going up faster in more affluent areas. Why is that? Well, I think that's probably because we're at saturation in poorer areas, because we've under-resourced general practice in poorer areas for so long that GPs and their teams have been stretching their capacity to desperately try and keep up with increasing need, but probably have got to a point where we just can't stretch capacity anymore. So actually we're seeing consultation rates increase in affluent areas faster than we are in poorer areas. So I think we've got to a point where the structural underfunding and under-resourcing of general practice in our most deprived areas is probably actively contributing to health inequalities as well as preventing us from effectively tackling them.
That consultation data, the way you can look at that and interpret it is quite different, isn't it? Like some people would say, well, that's a massive success that they're delivering so many more appointments in these parts of the country. But actually what you're saying there is it actually shows that there's real problems in parts of the country where they're not able to do that really. It's not got anything so much to do with demand, it's perhaps got to do with capacity.
Exactly. I think we know that, for example, patient satisfaction on lots of measures of things like access to general practice is lower in poorer areas. That's not surprising, is it, given what we've just talked about? It's also probably not surprising for people to know that general practice consultations are shorter in more deprived areas. As you have more health conditions, so people who have multiple health conditions do tend to get slightly longer in each GP consultation. But what trumps that is whether or not you're a person who lives in a deprived or an affluent area. So at all levels of multimorbidity, people with multiple health conditions get less time in GP consultations if they live in poorer areas. So everything is sort of lining up behind saying there is a serious supply problem. I mean, we know that there are supply problems across general practice more broadly. I'm not underestimating those challenges, but they are particularly acute in our most deprived areas. That will limit our ability to tackle health inequalities. This is not surprising given the way that we fund general practice. Our funding formula for general practice, Cahill, doesn't include any adjustment for health need generated by socioeconomic deprivation. So it's not as though this is an inexplicable phenomenon. This is an explicable product of poor policy making historically, but policy that hasn't been fixed.
So what needs to happen? Do we need a new funding formula? Is that what you would advocate for?
It is. I've spent years of time looking at this and trying to understand what the problem is. And I don't think it's as straightforward as just a new funding formula, but I do think that it would be impossible, in my opinion, to fix this without fixing the funding formula. So just to give a bit more context on that, if I may, as many listeners will know, core funding for general practice is by weighted capitation. So GPs get paid per patient per year with a weighting attached for, in theory, the workload associated with caring for a person with those demographic characteristics. The formula is called Cahill. It was developed in the late 90s. It's been used since 2004. Before 2004, there was something called deprivation payments. So effectively recognition from government that there was more health need in deprived areas and that GPs in those areas would need top-up payments to allow them to meet that need. That got taken away with the contract changes in 2004 because the idea was that Cahill was going to do it all, except that it doesn't. So the weighting in Cahill has lots of things in it, things like age, rurality, staff turnover and adjustment for morbidity, but no attempt to weight for health need associated with socioeconomic deprivation. So a paper several years ago now from academic colleagues in Leicester showed that for every 10% increase in the IMD score, indices of multiple deprivation score, you get an increase in practice payments of just 0.06%. We've known about this for a long, long time. So there was a formal formula review group convened in 2007, which reported in 2008 and said, Cahill isn't working. You need to redo Cahill. You need to include an adjustment for deprivation. It actually went to a vote of the profession in 2008 and GPs voted against it. I suspect largely because at that point there wasn't any additional money going to be made available. So it would have meant redistributing funding across practices, which we know is difficult. Review of Cahill was it's been promised in multiple national policy documents for general practice, including GP Forward View in 2016, but it hasn't yet happened. Something I did whilst I was at the Health Foundation with colleagues was to do a big piece of policy analysis looking across a range of ways to make the provision of general practice more equitable. So we looked at things like contracts and commissioning and workforce and funding. And it is clear that there are other things beyond formula reform that might make a difference. So, for example, schemes that target early career GPs and incentivise them to move into underdoctored areas do appear to work. That said, the conclusion that we reached from that big body of work is that the thing that hasn't been done for all of this time that we know really does need to happen is reviewing and overhauling that formula, replacing it with a proper needs-based funding formula for general practice that uses current data from now, not data from 25 years ago, that is fit for purpose and that allows us to more equitably distribute funding between practices based on an understanding of the need of the populations they're serving.
Is it possible to do this when there isn't, unless there's more money overall coming in? Is it something you can only do on a rising tide of funding? Because like you say, if you change the funding formulas, potentially winners and losers. So is it only possible to really do it when loads of extra money is coming in?
I think it's certainly easier to do it in a context of additional funding. If we brought in a new formula, which I don't know what the effect of the new formula would be, let's be clear, I think what we need is a formula that properly adjusts for need in populations and divides funding equitably between practices based on that. My guess, because Cahill does such a poor job with respect to deprivation, and based on experience in areas like Leicester and Rutland and Frimley who have implemented their own funding formulae, my guess is that you would end up redistributing some money towards practices in more deprived areas. Clearly, that is going to be easier to do in a situation where you can put money in so that no practices lose money. You just hold practices that are currently over-resourced relative to your formula at a constant level of funding and you bring other practices up. Putting money in will make that process easier because the broader context here is, of course, that general practice as a whole, I would say, has been under-resourced in the last decade. So this isn't a time of plenty. It's hard to take money away from anybody. But I don't think this is impossible if we don't have a huge amount of extra funding because there are choices about how we do this. First of all, you can do this in a staggered way over time. You can also choose whether you're trying to make this absolutely fair or fairer, so you can change your baselines. And what that really means is you have choices over how much you spend and how fast you spend it. There's no doubt that something like a primary care investment guarantee, so if government said we're going to commit to increasing the proportion of NHS funding that goes to general practice by 1%, or primary care and community care by 1% a year over the course of the Parliament, would that help? Of course it would, because that would be more than enough money to introduce equitable funding across primary care. But it can be done in a context of not having that money as well.
When we're talking about deprivation and practices in deprived areas, it's not just about money for the GP contract. I mean, practices get additional money for enhanced services that they provide from ICBs. Do you think that funding needs to be looked at as well and potentially more of it ring-fenced for general practice, perhaps in areas that have more deprivation?
Yes. We all know that demand for general practice is rising incredibly fast, and that makes sense when you look at projections for disease burden in the future. The majority of illnesses we expect people to have are things that general practice will be expected to manage. So set aside government's ambitions to move more care into the community. Actually, if we just think in terms of what diseases do we think that people are going to have and where will that result in them needing care, the answer is general practice. So I struggle to see any future in which we're not investing a bigger proportion of NHS funding into general practice. I do think there is also a legitimate question, though, about how general practice can assure, for example, Treasury, who ultimately hold the purse strings on this, that additional funding for general practice will improve patient outcomes.
What do you mean by that? Do you think that there needs to be changes in the way we measure things when it comes to, if we're putting more money in, do we need to change how we measure what's coming out from it?
I think we could probably be smarter about how we measure things. I think what I'm getting at is that my sense, and this might be wrong, it's a personal opinion, is that historically there may have been some reluctance from Treasury to increase the amount of money spent on general practice because it is harder in general practice to tie what you put into what you get out. So, for example, if you pay a hospital on a contract to deliver X number of hip replacements, you can say, did X number of hip replacements happen? Much, much harder to do that in the context of the type of undifferentiated care, really, that general practice provides, and particularly hard to do that in the context of the funding model for general practice, frankly. I don't think that means it's impossible. I don't think that's a fundamental challenge to the partnership model, but I think that's something we need to think about if we're continuing to advocate for the partnership model in general practice, is to say, how can we assure government that if you put more money in, which is what I think many people, definitely what I think should happen, I suspect many listeners think should happen, how can we reassure government that you actually will improve patient outcomes? Now, I also think that there is a wealth of international evidence that suggests that systems that have strong primary care are overall more cost effective, they have better patient outcomes than systems that are more hospital centric. So I don't think the responsibility is entirely on general practice to prove its case, but I do think it might help.
The government has said it really wants to move towards a model that's very much focused on prevention as opposed to treatment. You know, this is what it wants to do. But again, that's very, very, very hard. You can put a lot of money in that, but you might not see the outcomes of that, some of that work, for a really long time. So it's quite hard to measure.
It is, and I think it's another challenge. For example, I really personally like the government goal to reduce the gap in healthy life expectancy. But reducing the gap in healthy life expectancy isn't going to be something that you're likely to achieve in one parliament, in part because a lot of the interventions that you'll need to make to reduce that gap are actually really in the early years of somebody's life. And so I think that's probably something that government has to reconcile itself with. My personal take is that that doesn't mean they're the wrong things to do. I think those goals are great goals. We should be moving to prevention more than treatment. We should be attempting to reduce gaps in healthy life expectancy. And we should be putting those things in place now. We just should have realistic expectations over when we're likely to see benefits from them.
Successive governments have said they want this to happen, move more funding out of hospitals into community. It's just never happened. What do you think this government needs to do to make that a reality?
It's such a good question, isn't it? It isn't new rhetoric. Previous governments have just failed to turn rhetoric into reality. And I definitely hope that this will be the government that does achieve what they say they want to achieve. Probably the first thing I'd ask is, well, why have previous governments so often failed? I think the answer to that, slightly crudely put, is that they've stayed too focused on hospitals, is that historically, financial and workforce growth in the NHS has stayed aligned with hospitals rather than moving things into the community. So you can say that you want to move care into the community, but if where you're putting all of your money is hospitals, and if what you're doing is massively growing the number of hospital consultants, which is what we've done over the last 15 years, that's at odds with your stated ambition. And I think pretty clearly NHS structures skew power towards the acute sector, and unfortunately I don't think integrated care systems are an exception to that rule. If this government wants to be different to that, they have to really comprehensively align all of the policies and strategies that they're creating for the NHS with the vision to move care into the community. I think previously there's perhaps been a lack of agreement on why you want to move care into the community. So, for example, is it because you think that's going to make care cheaper? A side note is I don't actually think it will. It might make it better, but I'm not sure it'll make it cheaper. Is it because you think it's going to be better for patients? Is it because you want to reduce demand on hospitals? I think government needs to be clear about why it wants to move care into the community. And then it will need to take really concrete steps to making that happen. What precisely those are and how you sequence them will depend on the purpose. But broadly speaking, you're going to have to align all of your policies to that vision. And the big one is that you'll need to make sure that your approach to how you're investing in the NHS aligns with that, to how you're thinking about workforce planning and which staff groups you're developing and what your training structures are. You'll have to make sure that aligns with a proper commitment to moving care into the community. You need to make sure that you really do shift investment and that you really do address the balance of power between local and national, that you give and resource local areas to focus on what they know will meet the needs of their community. So this is pretty massive, but I think starting with why previous attempts have failed and moving from that would be a sensible position to go from.
Do you think this could be a platform to help kind of overhaul how general practice is funded as well and address those problems around deprivation too?
I really hope that it can be. I think there are intersecting things going on here. I think if government is serious about shifting care from hospitals into the community, I think it will need to spend more on primary and community care. And I hope that that would create the opportunity to make the redistribution that we talked about earlier an easier thing to do. I also think that the redistribution we talked about earlier fits with government's commitment to reduce the gaps in healthy life expectancy. Things are aligning behind redistribution of GP funding being more possible. And I've also been really encouraged in recent years to see the Royal College of GPs call for more equitable funding distribution and actually to see the BMA doing the same. And I think I'm not sure that that would have been the case 5-10 years ago. I think those are really big steps and I find them really encouraging.
Yeah, no, that's a good point, isn't it? There is kind of quite widespread acceptance that maybe the funding formula doesn't work properly anymore. And like you say, that wasn't necessarily the case a few years ago. So that is a positive step forward. One of the other things we also know the government is keen to introduce is incentives for continuity of care. There's a lot of talk of bringing back family doctor and making sure that people who need continuity can have continuity. How do you think something like that could work? Can we incentivise continuity and how can we measure it?
It's a really good question. I think that we can do it. I don't think it's going to be easy. We need to be clear about, for example, what type of continuity of care are we incentivising? Presumably, this is about incentivising relational continuity of care, but let's just be clear. If we assume this is about relational continuity of care, then what are we incentivising within that? We know that continuity of care doesn't matter for everybody. So are we going to incentivise it for everybody or are we going to incentivise it for some groups, and if so, who? Evidence suggests it's most important for older people and for people with chronic conditions. So that would seem to me to be a sensible place to start. And actually, are we content with saying those kind of broader groups, or there will be other groups, for example, for whom we know continuity of care matters, but are perhaps harder to spot? So the young, previously well person who presents with something that at first glance might look fairly straightforward, but actually turns out to be the start of a more serious and protracted illness and is somebody who really would benefit with continuity. So there will be nuance about who we say it matters for. And then I think another challenge is the measurement piece of it. So if we're going to incentivise it, we need to be able to measure continuity of care. And for me, at least, that's not actually straightforward. There are different ways of counting continuity of care. Are we saying it's continuity of care with the GP the patient most often sees? Is it with the GP the patient prefers to see? Is it with a named GPs? Those might be three different things. And then how do we measure it? So there are different measures available. There's the usual provider of care index, Bice-Boxerman, the St Leonard's Index. Each of those has strengths and limitations. None of them are perfect. None of them account for patient preference. So I guess what I'm doing here is setting out a series of choices that policymakers implementing this will have to work their way through. And the final thing I would layer on top of that is actually thinking about, well, what do we know about how incentives work in general practice? And how do we deploy that best in this context? One of the things I always worry about, and this is definitely borne out in QOF, practices who are in more affluent areas do better on QOF and get more income through QOF, is that actually incentives often widen inequalities. Continuity of care is going to be harder for some practices to improve on if, for example, they simply don't have enough GPs. or their GPs are all working a very small number of sessions per week. Those are structural factors that will make continuity of care harder to improve on. When we're thinking about literally the indicators that get used for this type of thing, is this about an absolute improvement, so saying you have to have X percentage of continuity of care for this group of patients, or is it about saying, well, let's measure your improvement from baseline and incentivise you to improve?
Yeah, it's interesting, isn't it? It's a bit more complicated than just say we're going to pay GPs a bit extra to do this. It's always a bit more complicated than that.
It wasn't a straightforward, bring back the family doctor. It's an easier way of phrasing it, eh?
Yeah, anyway, the government's just launched its call for evidence for its 10-year plan. And that's likely to be published next year. And we're probably going to have to wait till that so we see some more detail on some of the changes the government actually wants to make. Obviously, think tanks like the Nuffield Trust, like you'll obviously have a lot of thoughts about what should be in that 10-year plan. Aside from this shift from hospital to community, which we've been talking about, what else do you hope that plan will have in it?
I think, like lots of organisations, will be feeding in a mix of ways, including through the open public consultation. I don't think there will be major surprises in what we'll say, because it will be drawn from the massive body of our research work, which is available on our website. And broadly speaking, I think we'll be saying that key areas are capital investment. In general practice specifically, that really means investment for estates, but in hospital, that's about investment for things like scanners. We'll also be saying that we need longer term capital settlements for the NHS. We've been having very short financial settlements for the NHS, which makes planning for any form of big capital project, like how you might overhaul GP estates and make them fit for now, very difficult to do. We'd also be saying that we have to have more funding and better support for public health interventions. Of course, people will know that most funding for public health now sits outside the NHS, but we think that actually if you're serious about prevention, you're going to have to be looking at public health, so you can't just leave that out of the plan. Talking of things that might not be fully addressed in the plan, but we also think are really important, social care. It's so aligned to the NHS, and I think all GPs will understand that. We see so much in general practice that is to do with social care provision or the failure of social care provision, so much distress that causes. So listeners will, I think, intuitively understand that the health of the NHS is fundamentally bound to the health of the social care system, which frankly is pretty dire. So although government has been clear that social care is outside the remit of this plan, we will certainly be making the case that actually we think it's really important that there is a comprehensive plan for social care delivered quickly, because otherwise your ability to really improve things in the NHS is going to be compromised. And I think a really interesting thing to me will be seeing whether this government is going to be perhaps braver than previous administrations in talking to the public about the realities of prioritisation and trade-offs. We are in an incredibly constrained financial period, and therefore there are some really difficult conversations, I think, to be had with the public about what realistic expectations are of the NHS in this circumstance. And I'm so interested when I'm talking to other colleagues in general practice, because I feel like something I'm on the receiving end of from patients quite often and have a huge amount of empathy for is actually just a gap between what people expect from the service and what we can actually provide at the moment, given the level of resourcing we have and the massive increases in demand that we're seeing. So I think we will, at Nuffield, will be really interested to see, particularly as this public consultation exercise goes on in preparation for the 10-year plan, how open government are in talking to the public about those trade-offs and the difficult choices ahead.
One of the things that's likely to be in this NHS plan is this move towards a neighbourhood NHS. What do you think a neighbourhood NHS model should look like, and how do you think general practice should fit into that?
I'm not certain about what government thinks a neighbourhood NHS model is, and I've been trying to get clarity really, because I think it's very important. I think it's a rhetoric that it was certainly used a lot in the manifesto and in the run-up to the election. It continues to be used. At its broadest, I think this is probably about the shift we've already talked about, which is, shifting from hospital to community. I think probably community and neighbourhood are being used interchangeably here. So lots of listeners will have, I'm sure, identified the manifesto commitment to neighbourhood health centres, but there's relatively little detail, I think, on what that involves. It's unclear to me, for example, whether those are significantly different to Darcy centres, which, as we all know, weren't an unmitigated success. I'm not currently clear whether government is planning on sort of bringing back a more polyclinic type approach to this, But I do think that if we're talking about moving more care into the community, we should be thinking about, well, what are the services that we can deliver closer to home? And I'm definitely thinking of my patients. Paediatric services, for example, could probably be delivered closer to communities, and respiratory services. And, there are all sorts of things that people will be able to think about their own patient groups and think, oh, yeah, actually those clinics could happen in the community rather than in a hospital. I think the challenge that falls out of that is that, as we all know, primary care estate is really wildly unfit for purpose at the moment. So it's back to the point we were discussing earlier about investment, really, and capital investment in particular. If government wants to move towards a neighbourhood NHS, then very practically speaking, that's probably going to look like making sure that we have the buildings in neighbourhoods and in communities to be able to support a wider workforce.
The thing is, all of this stuff, it sounds great, doesn't it, on paper, but actually getting there, it's not so straightforward as just suddenly saying, well, yeah, we're going to do all of that and we're going to do it in that building there instead of in the hospital. Or is it as straightforward as that? Maybe I'm making it too complicated.
No, I completely agree with you. And I think that the history of these types of transformations in the NHS is actually often an underestimation of the challenge of doing these things. And there's always lots of talk about the NHS being overmanaged. My view is the NHS is often undermanaged, and particularly in general practice, actually, we're very light on management infrastructure. And if we want to do these things well, my view is that we need proper transformation support to do that. We need support with organisational development, with implementation.
The government said the NHS is broken. This plan is supposed to be the plan that's going to fix it, turn things around. Out of all of the things that the government has said it wants to do or things that it could do, what do you think it should prioritise if it wants to start making improvements to the NHS over the next couple of years, this Parliament term?
So I'm going to zoom out slightly, but obviously here I'm tempted, Emma, to say to you, primary care has got to prioritise general practice. And on some very deep level, I do kind of believe that. But I think just zooming out a bit, I think there are really big questions for government about priorities here. And I think, the first one is, well, what is the level of investment you're willing to put into this?
Mm-hmm.
Prioritising investment is really important. Prioritising workforce, absolutely key. There are things that you can do without spending money, for example, around capital, like giving the NHS longer capital settlements. So being clear on how much money you're going to have over a period of years rather than having these short-term settlements that means that the NHS can't plan. I do think that moving care into the community, properly resourcing general practice, doing it equitably should be a priority for governments. I think if you look at where the majority of contact happens with the NHS, where the majority of contact will happen with the NHS when we think about what the future pattern of illness is going to be within society, it is within general practice. And where you think about where the evidence is for how do you run efficient, cost-effective health systems with good outcomes, it's also in primary and community care. So big headline things on investment, workforce, super important. Actually, I do think, quite aside from my own personal bias, there is a compelling argument for saying government should prioritise primary and community care, and that shift is really important.
Yeah, I'm sure there's lots of people listening to this that will totally agree with that as well. And one of the final things I wanted to ask you before we finish, if there's other GPs listening to this and thinking that they'd quite like to get into policy work, what kind of advice would you give them if they're interested in a career doing what you do?
Gosh, Emma, I'm so lucky to have this job. And one of the challenges, I think, is that there isn't a clear career path. I think my generation of doctors overall, actually, were enormously lucky to benefit from things like academic training paths for those who wanted to pursue that. We don't have a policy equivalent. I think that can make it harder, but I don't think that's an absolute barrier to pursuing a career in policy work. In terms of gaining experience, and I declare a total bias here, which is that back in 2017, I co-founded something called Next Generation GP with Nish Manik and Ramya Matthew, which was aiming to energise, engage and empower early career GPs. And where that came from really was a feeling that at that time we were all still GP trainees, and that you don't really learn, or at least we didn't feel that we had learnt much in your GP training about things like how the NHS runs, what commissioning is, how finances work, how money flows through systems, and what that can lead to is people feeling quite disempowered and disengaged and feeling like lots of things happened to us as clinicians and you don't really get to change them. Now, that's a bit different in general practice, I think, actually, if you become a GP partner particularly. But we set up NextGen in response to that to try and help people learn more about all of those things that sit outside the direct remit of general practice but affect us so much. For me, I have learned a phenomenal amount, both through my involvement in NextGen, but also from listening to the speakers that we get. So for early career GPs out there, have a look at the website, have a look at whether there is a programme near you, and there's a podcast called the NextGen Cast. I would also really encourage people to think about local ways into this and talk to people, reach out to people. If you see someone doing something interesting, drop them an email and ask for half an hour of their time to learn more about what they do. And that could be your PCN clinical director who is dealing with policy at a local level. It could be somebody within your integrated care system with responsibility, for example, for general practice commissioning or for workforce. When I reflect back, I really feel like I came out of GP training pretty naive to the range of other roles that people were doing within the NHS, and pretty naive as to the ways that kind of central NHS policy worked. I was lucky to have opportunities through the National Medical Directors Fellowship to learn a bit more in a slightly more formal way, but I definitely don't think they're the only routes in. And I think being curious and reaching out to people and asking for bits of their time can be a route into finding a little bit more.
That's brilliant. Thank you so much for coming on the podcast, Becks.
Emma, thanks. It's been really fun chatting with you.
Well, that's it for this week. Thanks so much for listening, and thanks to Becks for speaking with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources to support you in your work on our website at GPonline.com.